All right. So we were talking about this slide. Osteochondritis dissecans, by far the most common site of this joint mouse. Subchondral fracture is the medial femoral condyle. But it can happen on the talar dome. It can happen on the distal tibia. They say it can happen on the capitellum or the radial head, although I've never seen one that I recognize there. But I have seen them on the talar dome, and you'll pick them up there, and they get a sort of a locking, kind of grinding ankle with that. And then we talked about patellar dislocation already. Let's talk about bursitis. This is a good little picture of all the bursa around the knee. And people often talk about, the swelling in front of the kneecap, and they call it suprapatellar bursitis, which is wrong. It's prepatellar bursitis. And people are like, oh, it's all the same thing. No, it isn't the same thing. Look where the suprapatellar bursa is. It's above the kneecap, more proximally, and it's a pretty important differentiation because the suprapatellar bursa in about a third of people is intra-articular. It's continuous with the articular space. So if the suprapatellar bursa is inflamed and open, it's possibly an intra-articular process, whereas the prepatellar bursa has no communication to the intra-articular space. So the bump on the knee, just like the bump on the elbow, and it goes by occupational names, so they call it washerwoman's knee or carpet nailer's knee. Just like the olecranon bursa, it can be a large, round, red sort of protuberant thing. Similar to the olecranon bursitis, you don't want to IND it. You should aspirate it. Similarly, it's micro-trauma, repetitive in 75-80% of the cases. And if there's no sign of infection, they don't need to be treated with antibiotics. It's drain and put a compressive dressing on it, protect it, rest it. If they do things like they're a carpet nailer or they're a carpenter that's on their knees and stuff doing framing and things like that, they need to stop doing that or put on a knee pad. And you'll see people on construction sites with those weird-looking hockey pads on their legs and protecting their knee. That's because they've had this before. There's an x-ray with a patellar dislocation, and they are the majority of the time out laterally. They shovel out to the lateral side, and just by extending the leg with gentle pressure on the patella, it'll drop back in. They're very satisfying. You usually don't need procedural sedation. The patient has a lot of anxiety about it, but it's not a particularly painful relocation process in the majority of cases. Now, posterior knee dislocations. I already talked about this a little bit in terms of anyone with bicruciate ligamentous instability. That means you should think about a knee dislocation. The vast majority of those are posterior. This is really common with an autoped where the lower bumper hits. They might have a tib-fib with a posterior knee dislocation. Remember, vast majority of knee dislocations do not present in a dislocated position. They present in an anatomic position, so you have to sort of figure out that it's that way. They can have perineal nerve injuries, particularly if the proximal fibula is involved in the fracture. Remember that nerve wraps around there and then trifurcates. Your orthopods will always come down and scratch that first dorsal web space between the great toe and the first of the other toes, because that's the deep perineal nerve sensory patch that they're looking at. Is there a deep perineal involvement? And then, as I mentioned, I don't care whether they have signs of vascular losses or instability in terms of the vascular injury, because even with a normal ABI and even with normal pulses, if they've had a dislocated knee, I think they should get a CT angiogram. Now, we have an x-ray of one dislocated down there on the right side here, and if you look at that, it kind of doesn't make sense when you look at it, and that's how they always look when they arrive dislocated, and that's because it went posterior and rotated 90 degrees. So those are the ones that won't spontaneously relocate. So on those, to put them back in, you just pull them out to length and rotate them back, and they usually go quite easily, but your concern for the popliteal artery as it crosses through the fossa should be high. All right, so there's both the quadriceps tendon rupture and the patellar tendon rupture. The image shown with patella alta, the patella's high riding, means the patellar tendon is ruptured. The one when the patella is riding low means the quadricep tendon was ruptured. You should be asking questions about fluoroquinolones. Let's say you took a week of oxyfloxacin right now. For how long would you be at risk for a tendon rupture? Over a year. That's how high the penetration is and how persistent the tendinopathy associated with fluoroquinolones is. Your highest risk would be for the first few months after taking that prescription, but the odds of having an injury, a tendon injury, are elevated a small amount for a year out. I always, as I say, you get the lower extremity fractures and injuries like the Maisonneuve and the Tillot fracture, you go to France. For some reason, when we talk about the patella, we go to Spain. Patella, alta, and abajo. All right, here's a sort of a three-dimensional recon CT of a tibial plateau fracture. You pretty knew, I'm sure the person who got this plain x-rays knew it was fractured. They didn't need the CT for diagnostic purposes, but plateau fractures often get a CT for operative planning. These are hard to repair and get anatomically in position, and so the orthopods really want to know how many pieces it's in before they go to the OR. Is the posterior tibial spine knocked off independently? Is the, how bad's the proximal fibula? How much swelling is there around the vascular or the nerve structures? And so CT is often helpful. What are the mechanisms here? Autoped, falls, those types of things. Having noted this really obvious sort of fracture that would be obvious on x-ray, and I suspect many of you in here had gotten an AP lateral and maybe even an oblique of a knee and did not see the tibial plateau. Tibial plateau fractures can be sneaky. They can be very subtle with just a double density sign, particularly when it's the lateral plateau involved. A person really won't bear weight for you, but I've seen people try and knee immobilize them, put them on, put them in a wrap and then send them out with crutches, and that's obviously not something you want to do. These are generally ORIF, and greater concern for things like compartment syndrome and such should be employed. Now here's you don't need to be a rocket scientist here. How long has your knee turned into a watermelon? So this person's got a giant this might have been a dislocated knee. I'd be certainly considering a CT angio on this without even laying hands on it, right? That's pretty exceptional blow up of the knee. And here's some other x-rays of various findings. You can see on the left side of this, there's a big intra-articular fragment and the proximal fibula is snapped off. And these are going to be real problems with prolonged rehab, complicated surgery, etc. Compartment syndrome, we've already made reference to a couple of times, pain out of proportion, and there's the 5 Ps on the top right, pain, pallor, paresthesia, paralysis, and pulselessness, but it's pain that occurs first and pulselessness that occurs last. So if you're waiting for the pulses to be diminished, you're waiting too long. This happens with crush injuries, complicated fractures, manipulated fractures, prolonged compression, high-pressure injection injuries, people on anticoagulants, including the novel oral anticoagulants, the novel agents do it, and bleeding disorders. The most common compartment syndrome in an adult is the anterior tibial compartment in association with a tib-fib fracture. The most common compartment syndrome in kids is a both bones fracture with a forearm compartment, not counting the Volkmann's contracture, which, as I said, is really a pseudo compartment. There's no true compartment at the elbow where you're getting the Volkmann's ischemia with a supracondylar humeral fracture. Here's tennis leg, I mentioned the 3 things that give you popliteal swelling and bruising. Tennis leg, it's called tennis leg because if you were playing tennis on clay and you were sliding with your sneaker in the clay and the clay's building up on the outside edge and you make your shot, and then as you push off through the ball of your foot against that lump of clay and try and get back towards the center of the court, all those forces come up the medial side of the gastroc. So it's a medial gastroc rupture. It may usually, and they're showing here that they're doing a Thompson test, and it will be normal because the soleus is intact, the other side is intact, the other head of the gastroc, and the Achilles is intact. So that's not going to be, the Thompson's test is not going to be a good test for this. It won't show you anything abnormal. Achilles tendon rupture, we're back to the fluoroquinolones again, steroids again. The person will often say they were kicked, they felt like a kick, they might have even heard an audible snap. Obviously the Achilles tendon is big. You may be able to palpate the gap when you compare one leg to the other. You may even notice the calf muscles balled up and more proximal because there's nothing stretching them out and attaching them to the heel. And they will have a positive Thompson's test because when you squeeze, there's nothing to make the foot plantar flex. There's no connection to the foot of all of those posterior compartments. Ankle dislocations, these happen. I'm always shocked when they happen that a fair number of times there's no fracture. It seems to me if you dislocate your ankle, you ought to break something, but a good third, even up to half of them in some series, have no fracture associated with them. They can go in any of 4 directions as listed here. They are associated with open malleolar fractures, and every once in a while you'll have a dislocated ankle, no fracture, but there's a wound, it's open. The skin popped open, and you can look in there and see the tin foil and stuff. And when you go to relocate those ones with that shiny articular surface and stuff going on, sometimes they won't go, and it's a really pretty easy relocation most of the time. Trust me on this, if you have an open elliptical laceration over the malleolus with this dislocation, and it won't relocate easily for you, what you should do is numb up the edges of the laceration and put a skin hook on the proximal side of it and pull on that, and then it'll go right in. It's kind of weird because it does not look like the skin is preventing you from relocating it, but the tension lines of the skin are doing just that. And so if you numb up that skin and put a skin hook in there while you're trying to do the relocation, it will pop right in. There are lots of complications to these. Neurovascular compromise and skin necrosis can occur. I've seen people leave them out saying, well, I want the orthopod to come in and do it. There's a fracture with it and things, and I want to mess with it, I don't want to be critiqued for it. And what will happen, and here's what is, that skin over the medial malleolus there is just going to die. That's under tremendous duress and force right now. It's got no perfusion whatsoever. And so really skin necrosis is a big part of this, but there's also other necrotic features that can happen. So the talus has a pretty complex vascular supply, and that's why talar fractures are, if you were to ask about, when we talk about AVN of the upper extremity, we're talking scaphoid most of the time. If you were going to talk AVM of the lower extremity, you'd be talking talus most of the time. And so this is one of the ones that you'd like to relocate. Again, you want to confirm their neurovascular status. These always are better. When you relocate them, their neurovascular status is always better. You might think, looking at this, that if it was on the appropriate side, a posterior tibial vessel might get nailed in that, but I've never seen that happen, and there are not a lot of case reports of vascular entrapment associated with relocation of ankles. So you should go ahead and do them. They're calling this an ankle dislocation. I don't know if I really would call it that. You can see how much shorter it is than the other side. Look at the relative heights of the talar dome. This is a pylon fracture where the talus basically is a wrecking ball and divides the distal tib fib and shatters them. So I'm not sure I would call that a dislocation. It's obviously not where it should be, and it may be laying anywhere anterior posterior with this, but that's really a pylon fracture more than a dislocation. Sprains, the anatomy is totally fair game. These are super common, obviously. Most of the sprains are on the lateral malleolar side and the lateral ligaments, and there they are listed for you, the anterior talofibular, calcaneofibular, posterior talofibular. After they've had a little time to swell and hemorrhage, you'll often see blood pooling on the plantar fascia along the foot planes. They might even have hemorrhage and bruising between their toes in a grade 2, grade 3 sprain. That's not uncommon. Compartment syndromes in the absence of anticoagulation are really pretty rare, though, in the absence of anticoagulation. Remember, the deltoid ligament is medial. The deltoid ligament is really hard to tear. All these lateral ligaments over here where the distal fibula is, those tear in bits and pieces, classic sprains. Everyone in here has sprained their ankle, I'm sure, at least once. And they hurt a lot, for sure. And they partially tear and give in little fits and things. But the deltoid ligament over on the other side is really thick and comes in 2 layers. And you'll see it disrupted, but it's usually completely disrupted when it is because it's so much tougher. The Ottawa ankle rules, here they are. You got to be able to walk on it. You got to have no bony tenderness. Remember, you're feeling the posterior edge of the fibula for bony tenderness, because if you feel anteriorly, they might have something. Right, all those anterior ligaments are there. You're not looking for a sprain. You're trying to find important fractures. And so those are the rules there listed out for you. Those are fair game. I think most everyone uses them at work, so they're pretty straightforward. They also include point tenderness of the base of the fifth metatarsal. Remember, in an ankle series, when you ask for an ankle series, you should see the base of the fifth metatarsal. Radiology techs are told to give you that, so because Dancer's fractures, Jones fractures masquerade as ankle injuries, and so they're instructed when you ask for an ankle series to give you the base of the fifth. Maisonneuve fracture, external rotation, and it can be a fracture of the medial malleolus or complete disruption of the deltoid ligament, and then it tracks up, tearing the interosseous membrane, and exits at the proximal fibula. And so it's a joint above and joint below pathology. The smaller arrow here shows no fracture at the medial malleolus, but an obvious unstable mortise with gap widening there. I mean, that's a good 2 millimeters wider than any of the other joint spaces, so that's blown. And so then you want to look up high for the proximal fibular fracture, and there you have it on the long arrow with a Maisonneuve fracture. Calcaneal fractures, and I remember in the beginning I've gotten this wrong because they'd ask what's the most common tarsal fracture, and it just didn't occur to me that the calcaneus is a tarsal bone. So again, little definitions and wordplay. The calcaneus counts as a tarsal bone, and it's the most common tarsal bone fracture. So I'd answer something stupid like the cuboid or the tarsal bone, the talus, when it is in fact the most common one is the calcaneus. Remember, anytime you see someone with bilateral calcaneus fractures or calcaneal fractures, that's a jumper, 2-3 stories, right? They flatten both their feet out. You got to worry about lumbar fractures and GU injuries. Which kidney is it going to be? If they were to ask, which kidney? They got hematuria and lumbar fractures. Which kidney is it? Obviously, it could be either, but it's much more likely to be the left kidney because the left kidney has more room in the retroperitoneal space to move because it's not held down by the liver, and it's got a longer vascular pedicle. So the left kidney is more vulnerable than the right. Bowler's angle, 20 to 40 degrees normally, is going to be flattened out in this. I never found Bowler's angle to be that useful, but it is useful to know what the numbers are for exams. Don't forget when you're suspicious of a calcaneus fracture to get the Harris view shot this way over the calcaneus and tangent. And the reason is I've seen, and I bet many people in here have also seen, you got an AP and lateral of the foot, the person won't weight bear, and you don't see a fracture. Then you get the Harris view, and the calcaneus is split right in half, but it's not that displaced. So I think the Harris view should be done anytime you're suspecting a possible calcaneal fracture. And here's Bowler's angle, and someone who's really got a pretty flat foot to begin with below in the x-ray. Little pes planus. All right, now we get to the fifth metatarsal. There's two versions, the Dancer's fracture and the Jones. The Dancer's fracture, and again, you don't have to know the eponymous names. They'll spell it out for you on the exam. Dancer's is an avulsion fracture of the base of the fifth. Don't confuse it with a normal ossification center, right? There are lots of accessory bones that can be in the fifth. So make sure they're really showing you an avulsion fracture and not the accessory bone that's right there, which is called os visceraneum. So there are like I said, about 10 accessory bones in the foot. These might be worth writing down. Os visceraneum looks like an avulsion fracture, and os trigonum looks like a posterior talar fracture. Os trigonum is sometimes made fun of by the radiologists as they call it os misdiagnosum because it's pretty common. They're common accessory bones that people misinterpret. So the Dancer's fracture with the avulsion, they can go out with a Cam Walker and weight bearing is tolerated because these do really well. They don't need operative intervention. The tendon sheath, which tendon is it? It's peroneus brevis. It has a broad insertion that's going to hold that down. The callus is going to form. It's going to do fine. As opposed to the Jones fracture, which is a transverse fracture of the diaphysis, that forms a teeter-totter mechanism and is at high risk for non-union and for getting worse. And so the Jones fracture is non-weight bearing. If they ask the difference between can it weight bear or not, the Jones, no weight bearing, and they should get fixed sooner rather than later. And there you see the peroneus brevis has pulled this thing off, and that's going to do fine. Cam Walker, pain control, they do very, very well. And here you see the Jones fracture, which doesn't look that bad. You're like, oh, no big deal. It's a fifth, metatarsal fracture. But those have this teeter-totter mechanism as the weight. So when you walk, you have a heel strike, and then the weight goes around the outside of the foot into the ball of your foot. And when it goes around that outside edge of the foot, heading up to the ball of your foot, it teeter-totters these two pieces apart. And that's why non-union is so high, and that's why the right-sided x-ray shows a cancellous screw has been driven in there to hold it and make sure it doesn't move. Lisfranc fractures and dislocations at the tarsal metatarsal joint. This is the key joint in your foot. Your foot has two arches. It has an arch from your heel to your front of your foot. That's the long arch of the foot. And it's got a transverse arch going from the lateral, the small part of the ball of your foot, over to the main part of the ball. So it's got two arches, intersecting arches. And the keystone for both of those arches is where that cuboid is, and it's the Lisfranc joint. So when the Lisfranc joint is blown up, the foot becomes unstable. Both arches are upset. These can be really obvious where the whole foot is diverged off and there's 3 or 4 metatarsal fractures. Those are really easy ones. But there are sneaky ones where there's just a tuft of bone between the first and second metatarsal, a little tuft of bone. That's called a flex sign. Some people say it's a real mother flecker because you don't want to miss it, because it's a signifier of of all the flex signs out there. Sagon's fracture is another important flex sign, but this is one that tells you there's something going on. There can be delay in diagnosis. This could happen in MVAs when you're putting your foot down into towards the wheel wells. You're not the driver, but you're hitting the brakes. And they often require ORIF. So here we see the step off of where the arrows are. So that second metatarsal is not matching up to the midfoot. And you can see the flex of bone in the middle. Those flex of bones can happen without the movement. Here we have some movement. I'd say it's at least a couple of millimeters shifted over. But you might see that flex sign without movement, and those are the sneakiest of Lisfrancs. And they're just as important because you might be able to save that person a surgical intervention by diagnosing it, making them non-weight bearing, and having them formally casted. Tarsal tunnel, like carpal tunnel, you can tap on it. Nocturnal pain, they get a claw toe. Pretty straightforward. Some other foot facts. March fracture, that's when you get put in some heavier soled shoes and you're a recruit for the military and they march you, and you get a stress fracture of the second metatarsal. Morton's neuroma, you could get Morton's neuromas all over the place, but when they're in the foot, because you weight bear through the foot, they're not tolerated so well. So you'll hear from surfers and skiers and other people who put a lot of downward forces on their feet. I got this pain between my toes and it feels like a cramp. And if you do a deep soft tissue palpation, you'll feel a ball that's often sort of about the size of your thumb tip. That's the classic Morton's neuroma. And those can be surgically removed with good relief. Metatarsalgia, pain in an obese female with recent weight gain. Boy, is that a nasty way of talking about pregnancy. But metatarsalgia is a pretty common problem in pregnancy, and often, it will be recurrent, but it's at the end of the day, right? Midday to the end of the day, as opposed to sole of the foot pain first thing in the morning. That's plantar fasciitis. So plantar fasciitis, pain on arising, and they can get it better with stretching and things like that. There's a lot of physical therapy that actually works for plantar fasciitis. Seaver's disease, or also known as secretary's disease, is apophysitis of the calcaneus. So we already talked about Sinding, Larson, Johansson, and Osgood Schlatter, which are all apophysities. But where the Achilles tendon inserts on the calcaneus, you can have an apophysitis there. And the reason it's called secretary's disease is because if your footwear is not good, in other words, if you wear a closed heel shoe, so for women that's a pump basically, that the top edge of the pump cuts right across where the insertion of the Achilles tendon is, and you can get an apophysitis there, aka Seaver's disease, aka secretary's disease. Some bone and joint infections. We've touched on some of these. Neonates, group B strep, but it's still mostly staph. Why is it group B strep? That's because they got the infection as they were crossing the birth canal. IV drug abuse. Syringes made of plastic and rubber. So it's going to be Pseudomonas. Anything that has wet plastic or rubber, I already talked about that, right? Yeah. Sometimes you'll see people, I remember the first time I saw this, I'm in our ER in county, and I'm looking at this ear, and there's this little black thing in the ear, and it looks like rubber. I'm like, what the hell is that? Anyway, I'm having struggling with it. Finally, I get the alligator forceps, and I pull it out, and I'm looking at it, and I'm like, I know what this is. What is it? And it is a little round circular piece of rubber. Finally, I figure out what it is in a TB or an insulin syringe, those little small ones that they use for heroin, right? It's the plunger on the end of that syringe. And the reason it's in the ear is because when you can't get good syringes and fresh syringes and you're sucking hot heroin into there and the thing starts cracking, getting loose, then you got the belt up and you've got the veins and you're going to inject your heroin and the heroin leaks around the stopper, that'll really piss you off. It's spilling out the back. So you need to get a bioocclusive for that syringe. So you'll harvest some earwax, then put your syringe back together. And if it comes off, that's how it gets in there. And if they get an infection in their ear with that, it'll be Pseudomonas. Sickle cell, gram-negatives, and salmonella, particularly, you got to worry about that. The foot puncture wound through the sneaker, again, wet plastic rubber, Pseudomonas. The cat bite, Pasteurella. How do they make Pasteurella? The unambiguous answer, they tell them someone's got a cat bite and they got this, this redness, and then they'll tell you that 6 hours after the bite, there's a lymphangitic streak. And that's how they make the answer not staph or strep. Staph or strep does not double and cause ascending infection at anywhere near that base. That's how they make that answer, because if you were to take any cat bite or scratch, it's mostly staph or strep. But if they tell you there's a lymphangitic streak 6-8 hours later, that's Pasteurella. Freshwater wounds, Aeromonas hydrophila, and those have caused some flesh-eating bacteria kind of things with freshwater wounds. Diabetic foot, polymicrobial. Interestingly, we almost always cover, and I'm sure you do too, your diabetic feet with Vanco. But if you look at your antibiogram for those infections, diabetic feet, they're less than 5% staph. They're really polymicrobial other stuff. Human bites, Ichinella. Reptile bites, Salmonella. We touched on all of that. Osteomyelitis. Remember that plain x-ray, really useless for osteomyelitis. You need to lose 25% of the bone matter, bone density, before you see changes on an x-ray. The earliest finding, if that's asked, on plain films is periosteal lift, so-called onion skinning. You might see a little periosteal lift early, but if you're looking for bone loss, you won't have it. And so if you want to look for it, then you do a bone scan or an MRI or other things. Osteogenesis imperfecta, blue sclera, a lot of fractures, gets better as they get older, sometimes mistakenly thought to be child abuse because you see a kid who's having their 4th fracture, and the blue sclera may not be that obvious to you, in a 12-year-old, and so you miss it. Usually by then the parents know, though, so that helps. Yeah, osteomyelitis. And I say this every time I look at this. Sir, did you notice the meteorite when it impacted your forearm? So they got this great big wound there. You can see the tracks going up in the upper arm. That's their left arm, so that means it's a right-hand dominant person injecting their left upper arm. So it's a right-handed, you all know this story as well as I do just from looking at it. It's a right-hand dominant IV drug abuser with AIDS and acute on chronic osteomyelitis with a cavern that's never going to heal. And you can see, even with that horrific-looking wound, there's pretty well-preserved bone. If you're looking for bone loss, it doesn't happen. Obviously, this has gone on for months. And they do have some bone loss, but not anywhere near what you'd expect. All right, into the spine we go. Let's, before we go too far into spine, let's lay some ground rules about spine. So, and I'm not a believer of teaching to the tort. I don't believe that medical legal cases are that instructive for learning emergency medicine, although a lot of time and breath is spent on it. But there are a couple things to know about the med-mal world and when you talk about it. And we know that if you're named in a case where there's a missed heart attack or a missed broken neck, you're going to lose that case. It's just, if you talk to anyone in the lay public, they kind of think you call yourself an emergency physician, they think you ought to be able to find a heart attack or a broken neck. And so we know that those cases are going to go against you almost immediately. The average, if you were to take a decent injury severity score and say, what's the incidence of broken necks and trauma in general? The answer is about 2% of significant trauma can have a broken neck. If you're a kid, what's the incidence? Does it go up or down? Goes way down, less than 1%. Some people say it's 0.2%, 1/10 of the baseline 2% number. If you're older, does it go up or down? Up. So it's like 4%. So 4% for the elderly, 2% overall, 0.2%, but definitely less than 1% for kids. Now, so we got those differences. If you're older, what part of your neck do you break? C1, C2. If you're younger, what part of your neck do you break? C1, C2. So at both extremes of age, old and young, the C-spine fractures migrate up. If you were to take trauma in general and a population like here in this room with a car accident, the place you break is C4, 5. All right, 4 lines of the spine, the anterior longitudinal ligament, the posterior longitudinal ligament, ligamentum flavum, and the spinal laminar line. Predental space, the atlanto-dens interval, and they like to ask this question, 3 millimeters in adults and 5 millimeters in kids. The littler people have the bigger space because as you get older, you're laying down bone from both sides, so the atlanto-dens interval is getting smaller as you age. Prevertebral soft tissues on a lateral C-spine film. These questions have sort of gone away because we don't look at lateral C-spine films hardly at all anymore. Most people with CT and neck that they were concerned about, and that is what ATLS says to do. And I still think there's a role for plain films here and there, but very few people are looking at plain films hardly at all. But if you did have a plain film, the prevertebral soft tissue numbers are 6 at 2 and 22 at 6. 6 millimeters at C2, the narrowest prevertebral space at C3, which is around 5 millimeters, and 22 millimeters at C6. Yeah, these lines of the spine, and in textbooks they're all wrong. So let's do the image on the left. All right? Line 1 is correct. That's the anterior longitudinal ligament. Line 2 is correct. That's the posterior longitudinal ligament. Line 3 is correct. That's ligamentum flavum. Line 4 is not correct. It should be drawn more to its left along the spinal laminar line. And the reason it's not over the tips of the spinous processes, although you'll see it in many textbooks, is because it's quite common to have a bifid posterior spine, which shortens it. So you can't follow the tips of the spines because if there's a bifid one, it'll look like malalignment. But even with a bifid spine, the spinal laminar line is correct. C5, 6, 7, they're there for you. These are oversimplifications. C6, generally biceps. C7, triceps. So if you have a patient who comes in a C-collar, maybe ejected from a motor vehicle, and their hands are like this, and you're like, sir, we need to put your arms down to get these x-rays. You go ahead and do it. And then you get your x-rays, and later on you come back, and their hands are up like this. You say, sir, can you put your arms down for me? And they go, I can't. What they're telling you is they can pull their arms up to scratch their head, touch their collar, because their biceps are in, but their triceps are out, C7. So you know now that the fracture is affecting the C6 to C7 level. There's no reflex for C8. This is 8 fingers doing C8. No reflex for C8, 8 fingers doing C8. Anyway, 5, so we got 5, 6, and 7 there. Again, we got C3, 4, and 5, right, keeps the diaphragm alive, and S2, 3, and 4 keeps the shit off the floor. So there's a bunch of important levels for you. And there, if you wanted to round out the list, here you go. L4 is the knee, and S1 is the ankle jerk when you're looking for people with low back pain. Nexus, finally accepted by ATLS, as was the Canadian. Are there any Canadians here? Do you practice in the States? Oh, this guy's just torture. You don't have to take this exam. You have to take that other one. The FRC exam in Canada is a real nasty oral exam. But yeah, just here for the hell of it, gambling, anyway. But Nexus and Canadian C-spine are in according to ATLS now, and remember the criteria that allow you to go ahead. They have to have no posterior midline tenderness, no intoxication, not even a couple of beers. Don't try and clear people with a couple of beers. No distracting injury, normal level alertness, and no focal neurologic deficits. They say it's 99+% sensitive. If you followed the Canadian C-spine rule, you'd be able to practice for 125 years, they say, without missing a fracture. And that's good given what happened to the stock market last week. I might have to work for another 125 years. C-spine injuries, how do they get broken? So the number one way is motor vehicle accidents, but more and more you see sporting things, jet skis, boating, skiing, snowboarding, you know, all kinds of middle-aged people doing stuff that they're really not limber enough to really be doing anymore. And so they get broken necks when that happens. 10% of C-spine fractures, this is really important, this is the third bullet, 10% of C-spine fractures are associated with another spinal fracture, and I would put a comma there, at a non-contiguous level. So if they have a broken neck, you are committed to imaging the whole spine. We don't know if it goes the other way. No one has ever taken a firm stand, and I don't believe it does. If you have a broken lumbar spine, are you committed to imaging everything above it? I don't think so. But we know that if you have a broken neck, you're imaging the whole thing. You're imaging the whole thing. All right, this is the image that we do, the Dennis three-column concept. So, if you were to add in front of where the words vertebral body were, if you add a ligament there, that would be the anterior longitudinal ligament. And the weight-bearing column of the spine goes from that anterior longitudinal ligament backwards to about 2/3 or 3/4 of the vertebral body. Of note, the posterior end plate of the vertebra is not in the anterior column. The middle column is the posterior end plate of the vertebra and the spinal canal. It includes the transverse process and the foramina and the pars. So that's the middle column. The middle column is anatomically the most complex. And then the posterior elements. And the reason we pay attention to the Dennis three-column concept is because if you have an injury of two, and it can be soft tissue or bony, an injury in 2 out of the 3 columns, then there's instability of that spinal injury, and it can move relative to the rest of the column. And if it moves relative to the rest of the column, then what happens? You transect, when it moves, the big nerve in the middle, because the big nerve in the middle is not going to do well if they move relative to each other. Hence the importance. So let's talk about stable C-spine fractures. There's a clay shoveler's fracture in the circle. That was actually named for being a clay shoveler in Western Australia. They'd have the big shovel with the wet lump of clay, and they'd be heaving it up into a dump truck. And as you heaved it up, because the clay was wet and there was surface tension sticking to the shovel, as you got this thing up to the top, at the very top, you'd have to pop it to get the clay to come off and drop into the truck. And that was back-breaking work, literally. It would avulse your C-spines of 6, 7, and T1. Minor anterior subluxations can be stable. A posterior arch fracture of C1 can be stable. A unilateral wedge facet can be stable, and wedge fractures can be stable. That's your stable C-spine injuries. Most of the other stuff you talk about is unstable, and they offer you up this politically corrected Jefferson bit off a hangman's thumb, which I really don't like. The original mnemonic, which apparently was too egregiously incorrect to be kept, was Jefferson bit a hangman's tit. Now, Jefferson bit a hangman's tit has a couple things going for it. It rhymes, and for the Shakespeareans in the room, it's in iambic pentameter, which makes it easier to keep in your mind. Unlike this horrific Jefferson bit off a hangman's thumb. The purpose of the mnemonic is to tell you about 99% of the existing unstable C-spine fractures, which is worth it if you find yourself looking at your own films and CTs, because knowing what you're looking for will help you find them. Jefferson's burst of C1, bifacet fracture or dislocation, that one's you'll never miss. Odontoid fractures type 2 and 3, you might ask yourself, well, what else happened to odontoid type 1? Odontoid type 1 fractures are stable because they're above the alar ligament. There are only 5 of them in the English literature. So they're super rare, odontoid type 1. The A is any fracture dislocation. The H is the hangman's, which is the posterior or middle columns of C2. And then the teardrop, which is the mid C-spine, the 4-5 one that's so common. Now, I remember the first time I saw this, I was not nice. I saw a patient come in like this, and the nurses called me up to talk to him. And I went up and I said, "Hi, sir, my name's Dr. Mallon. What's going on?" And he said, "If I don't hold this here, it's going to fall off." And I had never seen this before, and I was like, "And when was the last time you saw your psychiatrist?" Any other medical problems? And so it is well known that atlantoaxial dislocation, I've now seen 3 of them, associated with rheumatoid arthritis and ankylosing spondylitis, will cause this dislocation, dissociation, and their head falls off, and it usually falls off forward, causing an abnormal powers ratio, if you want to look that up. And it's a real problem for them. They have to figure out how to bolt their head onto them, and if you don't figure it out, they end up with airway problems and things like that. Now, most of the time, people with not most of the time, but a lot of the time, people with C1, C2 processes like this are neurologically intact. Why so? And the reason why so is that the high C-spine is roomy. There's this thing called Steele's rule. And what it says is that if you were to take a level through the dens and through the brainstem cord and through that part of your C-spine at C1 or C2, it would be 1/3 dens, 1/3 cord and brain, and 1/3 empty. That 1/3 empty is why so many people with C1 and high C2, dens injuries, things like that, are neuro intact. Okay, bilateral facet dislocation, very high incidence of cord injuries because the subluxation is so much. And so here you see someone who's not doing so well with their atlanto-occipital dissociation. And again, remember the rheumatoid arthritis and the HLA-B27, bamboo spine, all that kind of stuff. And this is a child where I suspect their head was literally pulled off. So it's not a classic thing. And look how big the prevertebral soft tissue swelling is there. I mean, C2 is 40 millimeters in that. And there's the bifacet. You'd never miss that malalignment, and certainly not on a CT either would it be missed. And obviously the cord has got some gymnastics to do in going from one level to the next, which is why they almost always have a level. Clay shovelers we talked about. Hangman's fractures, the middle and posterior elements of C2. Now, I just told you it's kind of roomy up there, and you don't want to have someone hang and suffocate. That's unsavory. Right, that's when they talk about hanging, right, you'd like to be well hung. Why? And if you'd like to be well hung, how would you get well hung? There's all this literature in terms about it. You would tip the hangman. And when you tipped the hangman, what would you be telling him? You'd say, please put the big bulk of that knot right underneath my chin so that when you drop me from a height greater than or equal to my own, I will severely hyperextend, snap my C2, transect my spine, get a boner, and be well hung. Have priapism. I would be well hung. And that's why you would tip the hangman. That's all true. What happens if you drop them from too high a height? There's some famous stories in the United States. I think it was in Arizona. It happened, right? Hangings were sort of good fun. Everyone, hot dogs. There was like the candy cane was out there. The town gathers. You're going to hang these people. And it really is a buzzkill when you drop someone from a little too high and their head pops off and rolls down the street. That ends the hot dogs right away. So that's all happened. And then if you don't have enough weight or you don't have the knot in the right position and it doesn't break their neck, then they're dying a strangling death and they run in air. And if you want to see that horrible YouTube video of Saddam Hussein, who was badly hung, running in space until he asphyxiated. So there's a lot of stuff about hanging and how to do it right. Done right, you should have a C2 fracture and die a quick neurologic death due to hyperextensive. This person is not a hanging injury. They have a middle third C2 injury, and I would expect them, because of Steele's rule, to probably be neurologically intact. And that's why when I look at this x-ray, they're also not intubated. This person is probably an autopsy photo. An autopsy film. I would not expect that one to be neurologically intact because there's just too much displacement there. Jefferson's the burst of C1. They always say things, and it says so in some of these. You'll see it in some places like here. It says diving injuries. That's really not true. Most diving injuries are hyperflexion and rotation when you hit the bottom. So they don't give you true axial loading. The most common way to get a good axial load is when your shoulder harness slips off your shoulder and you hit the roof of your car in a car accident. And so, but that gives you Jefferson's fractures. And again, because they're up high there, they may be neurologically intact, and they're considered to be unstable. Posterior neural arch of C1 can be stable when isolated. They also can be congenitally absent. So if you were going to talk about, make a brief list of normal variants, because you look at enough C-spines in your life as an ER doc, What are the normal variants of the C-spine that you could encounter? One is congenital absence of the posterior arch of C1, normal variant, stable. Two is congenital block vertebra, usually of the mid-C-spine where two of them are fused together. And the third, I already mentioned, cervical rib. Those are the three relatively common anatomic variants that are out there. Here we see a Jefferson's fracture where it's burst in the direction of the arrows. You see a little fleck of bone on the one side that was pulled off by the alar ligament. If you ever see a vertical fracture going down the middle of the dens, perfectly vertical fracture, what is that? It's the gap between their teeth usually. It's Mach effect, usually not a fracture. And there's a posterior arch of C1, probably stable, probably neurologically intact. And there's your odontoid classifications. We already talked about the atlanto-dens interval. We already talked about how C1 and C2 are really where the fractures are located in kids. And here you see the types of fractures. The odontide type 1, very rare, 5 in the English literature, stable because it's above the alar ligament. The odontide type 2, below the alar ligament, technically unstable, and the 3, unstable, but often neuro-intact. Now, when you're born with a big head, and the big head bone is connected to the neck bone, which means that C1 and C2 are also going to be relatively large because atlas and axis are attached directly to your skull, right? That's where you watch a tennis game, is C1, C2. All of that rotational stuff is attached directly to the skull. And then the rest of the pediatric spine is going to be small. So you have a big skull and a big C1 and a big C2, so it can look like there's overhang of C2 on C3, which is in fact normal. And there was this pediatric radiologist named Swiss Chuck who developed a way to tell pseudo-subluxation from actual subluxation because this radiographic finding is so common in young kids. Again, not often discussed anymore because we CT all these. But what you're supposed to do is put a dot on the spinal laminar mark of C1, put a dot on the spinal laminar mark of C3, connect them with a ruler, making that yellow line, and the spinal laminar mark of C2 should be within 1 millimeter of that line. And if it is, as it is here, it's exactly on it, then you know that big overhang of C2 on C3 is pseudo-subluxation and not real subluxation. This again happens a lot because the kids have the relatively large occiputs or they're a little flexed on the board. So if they're in radiology without having a roll under their, a little bit of a roll under their shoulders, you'll often have this finding on the lateral view. Teardrop fractures can be both flexion or extension, but they're mostly flexion. They have a teardrop-shaped piece of bone. It looks like it's only in the anterior column, but to get that teardrop-shaped piece of bone, you have to have unhooked the facets, torn the interspinous and the supraspinous ligaments, so it's a 3-column injury, and they are not intact almost ever. So here you see, it looks pretty good alignment on the left. You see that corner of the bone is knocked off, and it probably happened in flexion when it hit the vertebrae below it. That looks just like that could do that handily. But if you look at the interspinous distances posteriorly, the fractured vertebra is very close posteriorly to the one below it and very far from the one above it, telling you that there's soft tissue injuries all the way through the posterior elements. Those ligaments are torn in the level above. And so it's a 3-column injury, even though the fracture is only in the anterior weight-bearing axis. And then the one on the other side, on the right-hand film, you could see all of the loss of the natural lordosis and kipped forward, and that's definitely not going to be, that's also a flexion one, and it's not going to be neurologically intact. Unilateral facet, I mentioned it as one of the things that could be stable. You're looking for a bow tie, and the arrow is pointing to the bow tie if you use your imagination. They should have put it red on the film so you could find it. And these are rotational injuries where it perches on that side with the unilateral facet, and usually they're neuro-intact, and usually they're stable. If you were to give me a bunch of plain films and say, Dr. Mallon, go ahead and find the unilateral perch facet, I would be like, I don't know. They're sneaky, they're hard. On CT, it's easier. All right, now we're to sort of the money section. These spinal cord parts and these spinal cord syndromes, these are super high yield and definitely worth reviewing before any exam, okay? Here you see in this image that is showing the blue stuff is pushing back and hitting the spinal cord. So that's a HNP, as they would call it, herniated nuclear propulsum. And if it's a central or midline retrograde disc, it could pinch the cord. And that's a really common type of presentation to the emergency department with pain of that type. So the posterior columns, vibration and position. Lateral cortical spinal is the upper motor neurons. Anterior horn, lower motor neurons, and the anterior spinal thalamic tract, pain and temperature. That, you just got to review it a few times. We'll hopefully make sense of it as we look at the injury patterns. Let's do it. So that's the purple part that's ischemic is the anterior cord. So the the anterior cord is out. So the spinal thalamic tracts are out. The anterior area is the part that's out. But the posterior columns, position and vibration, will be in. And it depends on how extent it is. You can see the lateral cortical spinal tracts are maybe involved, maybe not. Right? So that is an anterior cord syndrome. Compression of the cord, there may be retropulse fragments. They have complete motor paralysis below, and vibration and proprioception are preserved. They often need surgical intervention to get those fragments out of the canal. All right, now let's do Brown-Séquard. Half the cord is out. These are often penetrating injuries, stab wounds, gunshot wounds, and so they'll have crossed findings below the level. Motor out on the IPSI, and contralateral pain and temperature out because of the decussation. So crossed findings. I call Brown-Séquard, to keep it straight in my mind, crossed. That way it helps me. Why do I call Brown-Séquard crossed? Because they have crossed findings and they're crossed modalities. Motor on one side, pain and temperature on the other. So it's a sensory process. Motor on one, sensory on the other. Central cord, sort of the darling of the examiners. It's a hyperextension in an older patient. Ligamentum flavum pinches the cord, and it gets the central portion of the cord to be ischemic. Remember that homunculus thing where they lay out your face and your arms and your midsection, your feet on across your cerebrum, right? And they say, oh, this is how the motor cortex is arranged on your brain. So if you have a stroke here, a lacunar infarct, you're going to have clumsy hand dysarthria because it'll be the hand in your face. But that homunculum goes from your motor cortex and it descends in fibers that when you get into the cord, it looks like an onion that's been cut in half. And the central rings of the onion are your face and your upper extremities, and the outer rings of the onion are your legs. And so with central cord syndrome, you have arm weakness greater than leg weakness because the central portion is out. They might have sacral sparing. These can be subtle, and I've seen people fooled by these, and they love to ask it on exams. Central cord system, totally fair game. All of these spinal cord syndromes, totally fair game. Transverse cord syndrome. We almost never used to talk about this. Tumors, trauma, transverse myelitis, but now we kind of have to because the transverse myelitis has been in the news lately, right? So neuroinvasive enterovirus D, whatever it was, 68, right, with the polio-like kids. That's a transverse myelitis. West Nile, neuroinvasive West Nile can affect the spinal cord. That's a transverse myelitis. And so transverse myelitis has been back in the news with viral illnesses, okay? Most notoriously, the enterovirus and the West Nile. Posterior cord syndrome can happen with trauma, but it more often happens with B12 deficiencies. They like asking about that. They get this imbalance in this flapping foot. It can also happen with tertiary syphilis and tabes dorsalis, and they have loss of position and vibration, which is what's in the posterior cord. So that occasionally comes up. They might give you the smear and say, here's an image of a smear. What neurologic deficit might go with this? You'd be like, the fuck? And on the smear is a hypersegmented poly, which is diagnostic for B12 disorder. And now you go from the B12 to the posterior columns, and you get the question right. That's devious. I know it sounds devious. Spinal cord injury without radiographic abnormality, more often seen in kids that have a hypermobile ligamentous spine. where they hyperflex their spine in an incident, which pinches their cord, but when they come back, there's no fractures or anything else. Usually cervical cord, as I said, they need MRI, they have normal radiographs, and early surgical benefit in some. We don't know which of these benefit from steroids. There's still some hope that steroids might help in some of these. Let's talk about the difference between spinal shock and neurogenic shock. These terms are used as if they're the same thing. Oh, he's got spinal shock. Yeah, neurogenic shock happens. No, they're not the same thing. So neurogenic shock, and as I have at the top of the slide, is the 70-70 disorder. That's to remind me that in neurogenic shock, systolic blood pressure 70, heart rate 70. That's what 70-70 stands for. It's not a pressure. Both are 70. And the reason that their blood pressure is low is because they've had a sympathectomy, so they can't maintain vascular tone, so they're vasodilated. And they've had a sympathectomy, so they can't get tachycardic. And so, what should you do for these? And they ask questions. What should you do first? 1, give them a fluid challenge. 2, give them a pressor to provide them exogenous sympathetic outflow. So they have unopposed parasympathetic, which gives them a relative bradycardia. They'll be flushed and dry. Again, if their sympathetic nervous system would be functioning, they'd be sweaty, but they don't have a sympathetic nervous system, so they're warm, flushed, and dry. Spinal shock, when used appropriately, is really sort of like a concussion of the spine. So there's some abnormal function. They may get it back. They may have some early reflexia or something like that, but they might have sacral sparing, and then over the next day or two, they start getting some neurologic function back. That's spinal shock. That's a concussion of the cord where they might have some recovery. Low back pain, everyone's joy. Low back pain, real problem, really, really common. Who gets low back pain? Everyone who walks on their hind legs. That's 1. 2, everyone who's overweight. Take me, for example. All of those people are going to have low back pain sooner or later. It's just super common. Mechanical low back pain is, I'll show you the slide that I love so much. I'll get back. I love this one. Mechanical low back pain, the causes. All right, 97% strain, 70%. Wait a minute, that adds up already to 170%. Degenerate 10% for, you keep adding it up, it adds up to like 225%. And indeed, many people who have low back pain have more than one cause, and it's really, really common. We see people with it. We try and be optimistic. We might give them short courses of, muscle relaxers or opiates, and we tell them that that's not the way to go, and they could get massage or acupuncture or anything else that they want to do to try and make it better. But it's usually self-limited as long as there are no red flags, and that takes us to the approach, which is look for red flags, and if they have a red flag, then they get worked up. I chart this all the time. You look for red flags. My red flag, my charts say, and I remember at Stony Brook when I started working there, they called me and said, Dr. Mallon, in your charts, you're frequently talking something about tuna fish. I go, yeah, leave that alone. Leave those, that belongs there. They're like, what? And it'll say, when I see someone with low back pain, I will say in the history, they're tuna fish negative. And tuna fish negative, because I do it the same way all the time, is a good way to look for the red flags. So T is for trauma. If they have trauma, they need to be x-rayed. U is for unexplained weight loss or other cancer symptoms. N is hard neuro findings, especially motor. I care much more about motor than sensory. A is age over 55. Some people like 60, some people like 65, but there are young cancers that go to bone, breast, right? You remember that mnemonic? Young cancers that go to bone, painful bones kill these suckers. So that's prostate, breast, kidney, painful bones kill these, thyroid, and skin melanomas. Those are that mnemonic, painful bones kill these suckers, is lytic lesions to bone from cancer. There are other things, but those are the most common, lytic lesions to bone. All right, so we got the A in there, that's tuna. Now we're on to fish. Fever. Obviously, if they've got a fever, I'm worried about infectious issues. The I is immunocompromised, IVDA. Any of that, I don't like. The S is for steroids. The H is for 3 of these histories. Any history of TB, history of cancer, history of HIV. And then the thing that's not included in there is have they had a recent procedure. All right, so I will chart tuna fish negative. I'm looking for red flags. They have none of them. They get no pain films. They get nothing. They get the best sympathy I can muster, some pain control regimen, discharge with follow-up PMD. All right, cauda equina syndrome. Cauda equina, the horse's tail. As the spinal cord gets off all of its nerves, by the end it becomes just the horse's tail. And if there's compression at that level, the first thing they get is bowel or bladder dysfunction. And that's why you got to ask about that. In those motor symptoms that I listed under tuna fish, for the neural findings, you're going to ask bowel or bladder in there as well. And they get overflow incontinence. So they have incontinence, but it's overflow incontinence. And one of the things that's newly found its way onto the exams, because the nurses now have all learned to do it, and they all have one, is what should you be asking for? Have them pee, check for a post-void residual. If they got a post-void residual of over a couple hundred cc's, that's abnormal, and you're worried about cauda equina and detrusor dysfunction, and then you're going to move on from there. If they have urinary retention, post-void urinary retention, now you're moving on to the MRI. We already talked about that with some humor. Spondylolysis and spondylolisthesis. Spondylolysis is there is a break in the bone, a discontinuity in the bone, and spondylolisthesis is they've slid on each other. Again, because the cord has the canal has become roomy at these levels, often they're neurologically intact down here. Low back pain workup. If you're worried about them, they're not tuna fish negative. If you're worried about infection, sure, you get the CBC, the SED rates. When I looked up, we did for the emergency medical abstracts, I think it's, 3 years ago now. We did, and I wrote the chapter, so I remember it well. But we did 25 papers on spinal epidural abscess. And all I could say after having read those and prepared those was that I was more scared afterwards than I was before. I was more convinced afterwards that I would miss it than I was, here's what you find when you read about spinal epidural abscess. First thing you find is the incidence of it is increasing rapidly. It looks, for sure, it's at least doubled, and most people would say the incidence of spinal epidural abscess has tripled. Why so? A lot more minimally invasive surgeries and LPs for pain control are happening, so a lot more invasive procedures. A lot more indwelling lines in cancer patients, where they might seed them from their PICC line or their port. A lot more of those. A lot more immunocompromised patients out there, people who are on chemo and things like that where they can get it. Finally, a lot more people on those what-the-fuck-you-mabs, the monoclonal antibodies that are immunocompromising. And so the incidence of this goes up. When you look at that literature, you find out that about half the patients that have it have no fever. I'm like, throw me a bone. I'm looking for an infected spinal canal. I can't even have a fever half the time. A lot of them are seen initially, they're neuro-intact with severe pain. The average number of visits until they're diagnosed, if you collated those 20 or so papers that I put together, is 3.5 visits. I like that because if I ever miss one, I'm going to claim that it's evident from the literature that the standard of care is to miss it. If it took 3.5 doctors to find it, then how bad can I be if I missed it, like everyone else did? And so the more you read about spinal epidural abscess, they usually do have pain over their back. There have been a couple recent doctor bashing papers that said all the findings for spinal epidural abscess were there, but the doctor didn't pick up on them. So I find the tuna fish thing as being a mechanical, same way every time approach. That helps me. And if I'm worried about it, they get a CBC, a SED rate, a CRP, cultures, and the whole thing, and then you start imaging. You'll get into an argument with your radiologist. You'll try and figure out where they are the most tender, and you'll want to MR that level, right? Because you feel like you're being ridiculous if you ask for the MR or the whole spine. And I will just tell you, having looked at this literature, it turns out that MRing the whole spine isn't that bad a strategy, because there are bunches of cases that were missed because the person did the L spine and they were just 2 levels below where it was. So they missed it. So be generous with your MR when you go to do it. Spinal stenosis, real common. CT, MR are where you're after. And a lot of people have spinal stenosis and bad symptoms. They all think they need surgery to fix it. And surgery does not really help that much. If you look at the bottom of this slide, decompressive laminectomy, it says, charitably it says, is not uniformly successful. These are about the numbers of people who have these kinds of degenerative problems with spinal stenosis who are just having horrible symptoms, either cervical or lumbar. when they go to the OR, about a quarter of them get better. Yippee, hooray. 50%, despite this horrible surgery, are the same. And 25% get worse. So 75% of the people taking the OR have no improvement or get worse. So the patients who are desperate all think surgery is the answer because they watch those TV things. Our minimally invasive spine surgeons, and they show the person popping up out of bed and going to the golf course, and they think that will be them. But it won't be if spinal stenosis is the pathology. Leg exercises, NSAIDs, PT, ultrasound, epidural steroids until they get a spinal epidural abscess. And here you see some images of lumbar spinal stenosis, but it's lumbar and cervical is where it happens most. Let's talk about these two fractures. Chance fracture, really important. We don't see it hardly anymore. It's when kid's in the back seat and there's a car accident and they pike over the lap belt because they don't have a shoulder harness on. And so there's distraction forces pulling apart their posterior spine. And Chance, as an orthopod, described it as being all three columns bony. But it can be mixed bony and soft tissue. And they may have bladder injuries, and they may have hollow viscous injuries. They may have a seatbelt sign. So we know a lot about this. And the transverse fracture is usually at the L1 or L2 level. They can have an ilius, very common for them to have an ilius. With chance fractures, because there's distension, and I've seen not a ton of these, but 3 or 4 of them in my career, they almost always have, it's not a hematoma yet because it hasn't had a chance to bruise, but they have an area of swelling in their lower back. You won't, if you actually rolled them and actually looked at their spine, you really wouldn't miss it. And they're very, very tender there. Now, burst fractures. Burst fractures and wedge compression fractures get mixed up, and we're going to look at that very carefully. And you're going to see why I emphasize that the anterior weight-bearing column does not include the posterior end plate. That's in the middle column. With that as preamble, let's look. So they're calling that a burst fracture there on the left, and it is. It's crunched. It's lost more than 50% of its height anteriorly. And is the posterior end plate involved in that fracture? Oh, yes, it is. And I'm worried about retropulsion of fragments, as is shown on the image on the right with the shorter, fatter arrow, showing a retropulsed fragment into the canal. What else lives in that canal? The big nerve in the middle. So I'm worried about the big nerve in the middle with burst fractures. And burst fractures are technically unstable because they involve 2 columns. And so they should be CT scanned from a couple levels below to a couple levels above. Now, there's a chance fracture pulled apart. All right, we talked about that. That's the classic picture, all 3 areas bone, but it can be bone and soft tissue. Now let's look at the wedges. They asked the levels, L1, L2, T12. That's the order of frequency. Usually there's not more than a 50% loss. Let's look at some pictures. So they're showing us this yellow arrow here. They're saying, oh, that's a wedge compression. Note, it didn't lose 50%. But look again. By definition, wedge compression fractures cannot involve the posterior end plate. Look at that image and ask yourself, does that fracture go through the posterior end plate? And the answer is yes, so that should be scanned. That's a burst fracture. They're calling it a compression fracture on here, but that x-ray is a burst fracture. The drawing, on the other hand, is correct, where the posterior end plate is intact. Orthotrivia adhesive capsulitis, we talked about that, any dislocation. Congenital hip, right, the Ortolani click test, where you're doing that frog leg thing. And what happens, when they have an unstable hip at birth, the hip comes out of joint posteriorly. So if you pull the knees up together and one knee's higher than the other, the one that's short is dislocated posteriorly. Whose sign is that? Someone might know that. That's Galeazzi's sign, the Italian guy again, coming to play. But that's his sign, not his fracture. So if one knee is shorter than the other, when you bring those knees together on the kid, that's Galeazzi's sign. Meralgia parasitica, burning lateral dysesthesia of the thigh from the lateral femoral cutaneous nerve, and someone who's wearing a work belt, like a cop, with all those, the mace and the things and the gun and all that on it, or someone wearing tight, stretchy pants. They're fabletics. It's the fabletic nerve pain. I love the pattern and the shooting pain down my thigh. We already talked about these age things, leg calf perthes, toxic synovitis, skiffy. We could talk about, and I just want to say, because someone asked me a question about this, in terms of Osgood-Schlatter, that has a really wide age distribution. You really can't pinhole Osgood-Schlatter into these small age things, right? Whereas leg calf perthes and skiffy, those are the 2 you need to know the ages on. Those are the 2 that can be bilateral. Those are the 2 you want to know. The skiffy is the older fat kid with the melted ice cream cone. Once I remember that, I can keep all the rest of them straight. Skiffy, older, fat kid, melted ice cream cone, can be bilateral. Torus fracture is buckled cortex, but not broken. Green stick, one cortex intact, the other out. We talked about these reflexes already. Paget's disease. Peter, did you do Pam P. Schmidt for hypercalcemia? So Pam P. Schmidt, now that sounds like a pain in the ass mnemonic, right? There's just too many. How many am I supposed to remember all those different letters? But the P in Pam P. Schmidt is Paget's disease. But you got to get it right because Paget's disease only has hypercalcemia during a flare. Most of the time the calcium is normal, but the alk phos will be elevated. And look at that horrible looking femur with Paget's. And if you weren't sure it was Paget's, they might show you a lateral skull x-ray with the punched out lesions that are characteristic of Paget's disease. Woo-hoo!